I'm Sarah Green. I'm the Executive Officer of the Health Services Research Association of Australia and New Zealand, and we're the hosts of today's webinar. The aim of the association is to build capacity in health services research in Australia and New Zealand, and we try and run 1 or 2 webinars a month on health service and policy research and methodology. And at the moment we're just focusing on the winners of our 2018 Best Paper Awards, and Haitham was the winner of our Best Early Career Researcher Award. Our other main activity is our biennial conference, and our next conference is being held in Auckland on the 4th to the 6th of December around the theme of health equity, and we have just opened the call for organised sessions, and that closes on the 5th of April. So if you have a suggestion, please take a look at the website, and the process for making a submission is on there. And I believe that the call for general abstracts will open at the middle of April. Just a couple of housekeeping issues for this morning. You should be able to see the slides and hear Haitham, but we can't see or hear you, but you can interact with us using the chat button. So if you've just got general chat issues, put them in the chat button. If you've got any questions for Haitham, what we'll do is we'll take those at the end of his presentation, and there's a Q&A button at the bottom of your screen. You can type your questions in there, and the chair this morning will keep an eye on those questions and pick out the most interesting ones for Haitham to address. And I'm going to hand over to Alison Pearce. Alison is a health economist at the University of Technology, Sydney, and she is a new member of our executive committee. So I'll pass over to Alison.
Thanks, Sarah, and welcome everyone. So I'm just here really to introduce Haitham, and then afterwards I'll moderate the discussion. As Sarah said, if anyone has any questions, just put them in the Q&A section and I'll make sure to read them out. So Dr. Haitham Tuffaha is an NHMRC and Senior Research Fellow in Health Economics at Griffith University. And his research encompasses the economic evaluations of healthcare technologies, and he has a particular interest in value of information analysis as a way of taking a really systematic approach to inform reimbursement decisions and optimize trial design, as well as prioritizing research funding decisions. And Haitham's a really promising leader in his field of research. He has over 50 peer-reviewed journal articles, book chapters and technical reports, and his research has influenced policy and clinical practice both nationally and at an international level. He is the chair of the Clinical Oncology Society of Australia, or COSA's epidemiology group, and also the co-chair of the Australian Clinical Trial Alliance Research Prioritisation Group, as well as being the secretary of the International Society for Pharmacoeconomics and Outcomes Research, the Australian chapter of that organisation. So I'm really excited to hear Haitham's presentation about the cost-effectiveness of germ-line BRCA testing in women with breast cancer, and also the cascade testing in family members of mutation carriers, because this is a really interesting and topical area in Australia at the moment. So thank you very much, Haitham.
Thank you, Alison, and thank you, Sarah, for organizing this. And I would like to thank HSRAANZ for the recognition and the opportunity. Before I start, I would like to acknowledge the traditional owners of the land. I want to pay my respect to their elders, past, present, and emerging. I would like also to let you know that this paper, this work was published last year in Genetics and Medicine, and I would like to take this opportunity to thank my co-authors, Andrew Mitchell, Robin Ward, Luke Connolly, James Butler, Sarah Norris, and Paul Scoffham. As you may have noticed, some of the co-authors are members of committees like MSAC, but we would like to disclose that the findings of this work under this paper particularly, they do not represent any committee's opinions. I would like also to acknowledge that I am funded by NHMRC as an NHMRC Early Career Research Fellow. I'll start with an overview about breast cancer. Breast cancer is the most common cancer affecting women in Australia. And this year, it is estimated that around 18,000 women and 150 men will be diagnosed with this disease in the country. Treatment it's out of scope of this webinar to talk in details about the treatment of breast cancer, but I would like to mention that treatment and prognosis of this disease depend on tumor stage and grade, as well as the presence of certain receptors such as progesterone, estrogen, and HER2 receptors, as well as the symptoms and patient factors and preferences. BRCA mutation is a germ-line mutation in the breast cancer susceptibility genes, so BRCA1 and BRCA2, and these are tumor suppressor genes, and any mutation in these is expected to result in higher risk of breast and ovarian cancers. So women with a BRCA mutation, they have between 40 to 80% lifetime breast cancer risk, and between 10 to 40% risk of ovarian cancer. It's important to remember that this mutation is autosomal dominant, which means it requires only one mutated copy in the genome to be inherited, which means that a person carrying a BRCA mutation has a 50% chance of passing on the mutation to their biological children. BRCA mutations can be inherited equally from either the mother or father. Epidemiology-wise, the prevalence of BRCA mutations is rare, but it varies based on a number of factors, particularly type of cancer. We can see it in prostate, breast, and ovarian cancer, for example. It depends on the age of diagnosis, family history, and ethnicity. So women diagnosed before the age of 40, at that young age, they have 10% chance of carrying a BRCA mutation. And this is regardless of family history of breast or ovarian cancer. This risk can go up to 20% if there is family history. And in certain populations, for example, such as Ashkenazi Jews, we have around 30% risk of BRCA mutation. So these factors are considered when we assess the risk for BRCA mutation development. Luckily, we have various proven interventions that can reduce the risk of cancer in BRCA mutation carriers. And for breast cancer, for example, we have a number of interventions, and the use of these interventions have become popular recently, with celebrities coming out to the public and being open about their condition and undertaking surgeries to reduce their breast cancer and ovarian cancer risk. So the options available are, in terms of surgery, we have risk-reducing mastectomy, which is the removal of the breast. Also, there is salpingio or oophorectomy, which is the removal of the ovaries. Or there might be, this can be done in combination, so both removal of the breast and ovaries. Some women may opt to have chemo prevention, using certain medications such as tamoxifen. That's an option, but its efficacy is not as high as surgery. Other women may prefer to take not to take any preventive intervention, and in this case, they might benefit from close and enhanced cancer surveillance. Now, because we can use these interventions to reduce the risk of cancer, and these are, and we know that there is a risk of increased risk of developing cancer with BRCA mutation. So genetic testing of this mutation has been recommended to identify carriers who would benefit from these cancer prevention interventions. But unfortunately, these tests come at a cost, and this cost might be out of reach for some individuals. And the other thing that because the prevalence of these mutations is low, so we have to test larger population to detect these mutations, which sometimes might not be cost effective. So health organizations and funders, they've been interested in knowing which genetic testing program would deliver value for money. The options that we have in terms of testing programs for BRCA mutation, we can be very broad and look at develop population-based genetic screening. So, and this can be helpful if we have a group of people that we know they have high risk of developing that mutation due to their ethnicity, for example, such as, again, Ashkenazi Jewish population. A different approach, which is a narrower approach, is to test people who have a family history of cancer, but in whom a familiar mutation has not been identified. So just based on having a family history of cancer. A more focused approach, which is now recommended by NICE in England and the National Comprehensive Cancer Network in the US, is to have to test affected individuals. So what we mean by affected individuals, those women who are diagnosed with cancer and who have disease characteristics suggesting a high probability of carrying a mutation. For example, being diagnosed at an early age, or for example, if someone developed what we call triple negative breast cancer, that's breast cancer where there are no receptors for progesterone, estrogen, and HER2. And then this can be followed by BRCA testing of the relatives of those affected individuals who test positive for the mutation. And this is what we refer to by cascade testing. So we move beyond testing the affected individual by offering this test to their maybe first and second degree siblings if their test was positive in affected individuals. Andrea and colleagues in 2016 actually, they reviewed the cost effectiveness of these approaches, these testing approaches. And they concluded that population-based BRCA mutation screening programs, they appear not to be that cost effective unless they are targeted at certain populations. On the other hand, family history-based testing programs appear to be cost effective, at least at that time, in 2 studies. However, one limitation and the major limitation in these studies was that they did not model the cascade testing among the relatives of mutation carriers. So they offered the test to the affected woman, and that woman would benefit from cancer preventive interventions. But they did not offer, and they did not look at the downstream costs and benefits of testing the relatives of affected women. Now, for the programs that are based on testing affected individuals, there was only one economic evaluation, and again, that evaluation did not consider the cascade testing of their family members. So the question was, the aim of this study was to assess the cost effectiveness of BRCA testing in women with breast cancer, and also the cascade testing for the relevant mutation in first and second degree relatives of affected women who test positive for that mutation. And that is compared with no BRCA testing. And that was an important decision problem for the government to know whether they can reimburse this test or not. So what we did to address this aim, we built a decision analytic model using triage, And that model was used to develop to compare the costs and effects of testing compared with no testing. And we included 3 cohorts. The first cohort was the affected women, and where they have high probability of developing breast cancer. So these women were women with unilateral breast cancer. That's cancer affecting one breast on one side. And also they might have family history or certain risk factors, and their score, total score, that predictive of the mutation presence is greater than 10%. This is the threshold that we used for high probability affected women. For the first degree family members, these include siblings and children of the affected women who test positive. And then the second degree family members, these are the children of siblings of the woman who tests positive. So if you look at the model, it starts with decision tree, where we have 2 arms of testing and no testing. And when there is BRCA mutation, we estimated that for every affected woman, there is on average 0.8 female sibling and 0.8 female, 1.8, sorry, female children. And these were followed, they were entered into a Markov model. And as you can see, we have a number of health states. So individuals identified or included in the model will be either in, they have either BRCA positive or BRCA negative. So they have a mutation or they don't have the mutation. For those who have the mutation, they can benefit from any of the preventive interventions. That could be radical mastectomy, that's again removal of the breast, or removal of the ovaries, which is bilateral salpingo-oophorectomy, BSO, or a combination of the 2 surgeries. We did not consider in the base case analysis the option of chemoprevention, because this is not really a very common option, and also it is not that effective. However, we tested that in sensitivity analysis. So after undertaking these interventions, women can stay in any of these healthy states, or they can progress and develop cancer. And we focused on the 2 cancers here, ovarian and breast cancer. Again, they can stay in that healthy state of cancer, or they can receive, of course, treatment and get cured. And at any healthy state, women can die of any cause. So these are this is a summary of the healthy states included in the model. But the strength of this model is that it is integrated. So we've integrated the cohorts into one model, and this was important to reflect the impact of detecting a mutation in the affected individuals and the cascade testing for their family members. I will come shortly to how we estimated these figures of female siblings and female children. As any model, we have to make certain assumptions. So the assumption was that the mean age of affected women and their siblings is 40 years. So this is the age they would enter into the model. It's worth mentioning that the mothers of affected women were excluded. So we did not include them in the testing or for the follow-up, because at an average age of greater than 65 years, there is low utility and low benefit of undertaking any surgery in order to prevent future cancer. Now for the children, it was based, the average age for the children included in the model was based on the assumption that The childbearing age in Australia is around 30 years, and assuming that those women were diagnosed at the age of 40, so this means that the average age of their children is around 10 years old. The other thing is, you might have noticed that we only focused on female members of the family because, again, the testing in terms of cost was offered for all individuals at risk, men and women. But for the follow-up, there is also low utility for men because they cannot benefit from any of these surgeries to prevent future cancers. And the men population affected with this disease is really small compared to the women population. Now, how we calculated the average number of siblings to be tested and followed in the model. So this is the affected person, which we call a proband. And based on an average of first generation household of 2.6 children, this data is from the Australian Institute of Family Studies. So we assume that every woman here will have, every affected woman will have on average 0.8 male sibling and 0.8 female sibling. We also assume that that woman belongs to a more modern household with lower number of children. So we assume that this woman would have 2 children, 1 male and 1 female. And for the second degree family members, these are the children of the siblings. So they will not be, of course, automatically tested. This depends on the presence of the mutation in their parents. So the chance for a male sibling or a female sibling to develop the mutation is 50%, as I said, because it's an autosomal dominant mutation. So with 50% chance, this makes the average number of male siblings with a mutation is 0.4, and with this probability, we will have 0.4 female sibling. The same for the female sibling as well. So altogether, we have, for every affected woman, we will have 0.8 sibling, female sibling to be followed, and 1.8, that's her child, and 0.8 children from her siblings will be followed in the model. Of course, all these assumptions were tested in sensitivity analyses at the end. Another important assumption is about the timing of when affected women and their family members would make a decision about which strategy to undertake in order to reduce future cancer risk. And we assume that affected women and their siblings at the age of 40, they would be undertaking these interventions within 1 year because of the increased risk of ignoring that mutation. And we assume that at that age, they would have completed their families, so they might be keen to undertake surgery to remove the ovaries or the breast to reduce their cancer risk. Now, for the children, we have to make that assumption that, of course, when they are under the age of 18 or 21 in some countries, they cannot consent to undertake any of the interventions, and it's not proven that these children can benefit at this early age from these interventions. So we assume that those children will be, of course, identified. They will not be, tested until the age of 20. And then they will be offering, of course, counseling, and then they will have the decision to undertake any of these strategies. And we assume that it will be around the age of 30 when they act on their cancer reduction by taking surgery, for example. The model was populated by the best available evidence from the literature at that time in 2016 when we did the analysis. And I will just summarize the main inputs. So a major input was the probability of an affected woman having a BRCA mutation. And we said that at 15% because the threshold to include this woman was 10%. And that probability ranges between 10 to 20. So we selected 15 as a point for the probability of developing BRCA mutation. Another important consideration that instead of using a fixed rate of developing breast and ovarian cancers for those who are not tested, for who did not go risk-reducing surgeries. So that was not just a fixed rate. We followed an age-specific incidence. So the incidence of cancer changed according to age, which is what we see in practice. Also, some studies, they modeled BRCA1 and BRCA2 separately, but in our base case analysis, we used a weighted average risk based on 54% and 46% prevalence of BRCA1 and BRCA2 respectively. But we also tested the impact of testing each mutation separately in sensitivity analysis. Another important consideration was the probability of undertaking a particular intervention to reduce cancer risk. We used the figures reported by Collins and colleagues. That's an Australian study where around 54%, more than 50% of participants, they opted for to remove the ovaries, 30% would remove their breast, and 16% would remove both the breast and ovaries. In terms of efficacy, we know that when the breasts are removed, there is 90% reduction in the risk of breast cancer. However, when the ovaries alone are removed, that percentage drops to 50% for breast cancer, but it's still 80% reduction for ovarian cancer. Combination of the two surgeries expectedly would maximize benefit, and that was assumed 90% reduction in the risk of both cancers. Utilities for the health states in the model were based on EQ5D 3-level scores, and these were assigned to all the health states available. It's worth mentioning that we did not include these utilities from surgeries because there was an assumption that these will be offset by improvement in utility from assurance provided by the ladies undergoing these cancer-reducing interventions. In terms of the cost of the test, so the test would be full gene sequencing test. That's we will be looking at the full gene for the affected individuals, and if there is positive mutation, that would be confirmed by looking at a particular site in that gene. And for the siblings and the cascade testing, there will not be a full sequencing, but the test will focus on that particular area where the mutation was detected. This will also include the cost of counseling before and after the test for every individual tested. Other costs also were obtained from local figures from MBS items and other publicly available data from Australia. So the analysis, this cost effectiveness analysis, was from the perspective of the health system, healthcare payer. So which means we looked at the direct cost to the Australian healthcare system. So we did not consider any out-of-pocket cost to affected women and their family members. All costs were presented in 2016 Australian dollars, and the time horizon of the analysis was all patients or all women included in the model were followed until the age of 90. That's almost lifetime. And we tested two scenarios. Actually, scenario one was the cost effectiveness of BRCA mutation testing of affected women only compared to no testing. And scenario two, that was testing affected women and the cascade testing of the first and second generation, and second degree family members of affected women who test positive compared to no testing. And we calculated the incremental cost effectiveness ratio, which is the difference in cost divided by the difference in effectiveness. And the main effectiveness outcome was the quality adjusted life years gained, QALYs gained. We also looked at other outcomes such as survival. We looked at the cumulative breast cancer risk and cumulative ovarian cancer risk in each cohort. For the base case analysis, we set the willingness to pay per incremental quality adjusted life year gained at around 50,000 Australian dollars. And we applied an annual discount rate of 5% to both effectiveness and cost outcomes, inputs. So what did we find? For scenario number one, that is comparing no testing to testing BRCA mutation in affected women only. This scenario resulted in an incremental cost of around $1,880 and 0.1 QALYs gained. This would result in an incremental cost effectiveness ratio of approximately $19,000 per quality adjusted life years. If we want to compare this to the assumed willingness to pay threshold, which is $50,000, so this scenario appears to be cost effective. In addition to this gain in quality adjusted life years, the model predicted that there will be a 0.09 gain in life years and a reduction of 0.04 on average, 0.04 and 0.01 breast and ovarian cancer events, respectively. So what about scenario number two, that is extending the program to cover family members? This scenario resulted in an incremental cost of $2,500, which is expected because we are expanding the testing. But it also resulted in 0.17 quality adjusted life years gained. Again, these are average per woman included. So that would result in an ISR of around $15,000 per QALY, which is cost effective as well. In terms of clinical benefit, scenario two would result in 0.7 life years gained and around 0.1 breast cancer events and 0.02 ovarian cancer events avoided. And this table actually summarizes the results for in terms of cost QALYs and incremental cost effectiveness ratio, the life years gained, breast cancer events, and ovarian cancer events. And as you can see, the ISR per QALY here for scenario one is higher than that for scenario two. But when we compare the two scenarios, we looked at this column, we looked at the difference in the increment. So we can see that we will have, for an additional $665, there will be an additional gain of 0.07, and that would translate into $9,500 per quali, an ISR of around $9,500 per quali. This is again comparing scenario 1 to scenario 2. It would also result in an additional 0.06 breast cancer and 0.01 ovarian cancer events. So the important message that we have found from this analysis is that expanding the program to test affected women, followed by cascade testing of family members of affected women who test positive for the mutation, maximizes the economic and clinical benefits of testing, as you can see. We wanted to validate our results, and it was really difficult to compare the cost-effectiveness results with other studies because, as I have previously mentioned, at that time there were no studies including cascade testing, but our results were comparable at the affected women level only to other studies that looked only at the affected women and did not look at their cascade, at their family members. But we also validated our model by looking at the predictive value of our model in terms of cancer risk, ovarian and breast cancer risk. And as you can see, our model predicts that for BRCA carriers, there is around 53% cumulative risk for breast cancer and 25% risk for ovarian cancer. This is very much in line or within the ranges of 50 to 60% cumulative probability for breast cancer and 20 to 30% probability for ovarian cancer risk reported in 2 large meta-analyses by Antonio and colleagues and by Chen and Barmigiani. As I said, it was important also to look at the robustness of the results. So we've undertaken sensitivity analysis, and the model was, and the results were actually more sensitive to the discount rate. And this is expected because we're modeling different generations. So it's the lifetime, for example, of children, following them up to 90 years with that discounting may affect the overall benefits of the testing, which is conservative, really. The probability also, the results were sensitive as well to the probability of BRCA mutation positive in affected individuals and the start age of affected individuals, as well as the uptake rate of genetic testing and preventive surgeries. Probabilistic sensitivity analysis was also undertaken, and as you can see, there is 85% chance of that intervention of testing being cost-effective for women only, and 90% chance with the cascade testing. So in the sensitivity analysis, this is the deterministic analysis. So we try to vary the estimates around the input parameters and to see their impact on the results. And as you can see, for the 2 scenarios, changing probability of BRCA mutation being positive, or even reducing the uptake rate up to 50% or different uptake rate of risk-reducing interventions did not really or significantly alter the results. And most of the time, all the time, the ISR was below the threshold of $50,000 per quali. So the cost-effectiveness analysis in this study demonstrates that testing of women with breast cancer who have at least 10% risk for BRCA mutation is really cost-effective compared to no testing. And as I said, this is supporting the recommendations from NICE and from other international guidelines that BRCA testing can be targeted towards women with a high probability of developing BRCA mutation, and then to test their relatives if they test positive. One strength that I've mentioned is the use of integrated model to analyze to incorporate the cohorts into one model, and that allowed us to estimate the downstream costs and benefits of testing family members as well. And as we have seen in the results, although testing family members would result in additional costs, the benefits of testing and risk-reducing surgery would definitely offset the additional cost of genetic testing. Of course, our work has some limitations in terms of generalizability. This was an Australian study, so the cost may be from the perspective of the Australian health system. But we still believe that the results in terms of quality-adjusted life years gained also, and the expected reduction in ovarian and breast cancer events can be actually generalized to other jurisdictions, because we used international studies, and the outcomes are expected to be similar. The other thing that although we've identified the best available evidence to populate the model, a number of assumptions, and we believe these assumptions were well informed by experts and trying to make them realistic. We had to make these assumptions. All these assumptions, as you've seen, were tested in sensitivity analysis. An aspect that was not considered in our analysis, but we'll be hoping to address in future studies, is the impact of identifying BRCA mutation in guiding treatment with the new targeted agents, such as PARP inhibitors, for example, using olaparib in breast cancer, women with breast cancer who have this mutation. So in conclusion, implementing a BRCA testing program in women with breast cancer who have at least a 10% pretest probability of having a BRCA mutation is likely to be cost-effective compared to no testing. However, expanding the program to test affected women, followed by cascade testing of family members of affected women who test positive for the mutation, maximizes clinical benefits and improves value for money beyond testing affected women only. This approach is more focused, more targeted, compared to a broader approach whereby population screening is required to identify women at high risk for hereditary breast and ovarian cancer syndrome. Just to let you know that a direct result of this analysis was the reimbursement of BRCA gene tests. So now this test is funded by the government for both affected women who meet the criteria of who have greater than 10% risk of developing BRCA mutation, and the family members of those women who test positive. With this, I conclude my presentation. Thank you very much for listening, and I'm happy to take your questions.
That's great. Thanks very much, Haitham. That was really interesting. Now, if anyone has any questions, as Sarah explained at the beginning, if you go down to the bottom of your screen, you'll see a Q&A button, and you can click on there and type in your question, or you can also use the chat button, but the Q&A section is specifically designed for putting in questions. So if anyone has any questions, just type them in there. While they're coming up, Haitham, I had a question for you. I was interested in the fact that you limited your model to only include women and testing them. And my understanding is that the results of BRCA testing for men have a much more limited implications in terms of how they're managed. But I wonder if you could talk a bit about that, and maybe also what you think might happen to the results if you did include men within your model.
Yeah, so that's an excellent question. Thanks, Alison, for that. So with all genetic testing coming up, it's important to look at two things, really. It's the validity of the test, its ability to detect a mutation, and the clinical utility. So what do we expect to do after we detect that mutation? Now, in our model, for example, and in this case, we have men affected with breast cancer, although this disease happen to men, although at a lower rate. So we included them in the model in terms of cost. So they were tested, and the results of the test informed the testing of their siblings. These are the second-degree relatives to the affected woman. So they were not really ignored, but we did not include them in the model to be followed because there is no utility, there is no, they cannot benefit from the intervention, the surgical interventions. However, for those men and for women who did not choose to take any of the interventions, our model assumed that they will be benefiting from surveillance, so they will have close follow-up because they might be developing other cancers, for example, like prostate and others. So there was a cost of additional surveillance for those men tested.
Okay. Oh, that's really interesting. Thank you. Now we have a question here from Anne Tran, who's asking the probability from post risk-reducing mastectomy, post risk-reducing ovarian cancer, surgery, and post both surgery to ovarian cancer. Did you take into account that the women have a positive test result, or did you just take the probability from the general population after they've had these risk-reducing surgeries?
Yeah, that's an excellent question. That's the risk based on, so we have two cohorts, the BRCA negative, BRCA positive. For BRCA negative, they took the probability of the general population. For BRCA positive, they took the probability in the literature from BRCA positive population. So yes, we've considered the BRCA mutation status when we populated the model with these probabilities. Okay, that's an excellent question.
It's tailored to their
yes, based on their mutation and age.
And age as well. Okay, yeah. Excellent. We just got so Anne Tran says thank you for that response. Yeah. So I've got another question, which it comes up with every model, I think. But I was wondering if you could talk a bit about how the results might change if you took a broader perspective. So you included some of the additional, not just the additional costs, but perhaps also the additional utilities that come from feeling a sense of reassurance that you know your test results, that you can tell your children, perhaps that your children could undertake fertility interventions to ensure that they either avoid having a child with that mutation, the kind of longer term implications. How do you think your model and your results might change if you took a broader perspective?
Yeah, that's a very excellent question. And we've been thinking about all these considerations, but so for example, as you said, we did not have enough evidence about the utilities. So we have some disutility evidence around the disutility from surgery, but we assume that these will be offset by assurance, but we don't know by how much. And we tested this in sensitivity analysis, which is very important. But another important dimension, as you mentioned, maybe certain technologies to enhance fertilization or to preserve fertility, these different aspects and components of family planning in the future, or what we can do around these, and also the downstream of implications and the trauma or impact that these results would have on individuals. So that's another important consideration, and maybe it's something for future research, and also patient preferences around when we assume that patients or affected women would take these interventions and their siblings would take these interventions, but there might be certain preferences for them, and these were not included because we did not have evidence around them. So we assume this is the uptake rate up to our knowledge, and based also on some clinical expertise. Although we varied this in sensitivity analysis, and we don't expect these to alter the overall results, but it is worthwhile looking into this and to know if we can target this screening program to maybe have it, making it more targeted, maybe, or to maximize benefits for certain people. Yeah.
Okay. Oh, that's interesting. Thank you. So Anne Trans put up another question. And so she said, I see your Markov model. Should it actually be 2 Markov models instead? So one if for true positives and one if for a false positive result, because she doesn't see an arrow going from positive to negative. So should the first branch actually have 2 branches and then 2 Markov nodes, one for positive, true positive results and one for false positive or negative results?
Yeah, that's a typical when you have diagnostic tests is to consider false positive predictivity, the specificity and sensitivity of the test. However, in this case, because we consider that this test is almost perfect, so it has a perfect sensitivity and specificity, and it was followed by a confirmatory test for that specific site. So the assumption was made that there is no false results because there were a confirmatory test done afterwards, and then that for the siblings or for the second degree relatives, we only looked at the specific site of the mutation because that site was already known. So typically when you have diagnostic tests, you need to consider these, but in this case we considered that it's perfect.
Oh, that's really interesting. Thank you very much for that answer.
Yeah.
So does anybody else, because we've got quite a few people on the line, does anyone else have any questions for Haitham? Any other burning issues? We'll just give people a few minutes in case they're
that's
slowly.
Thanks, Alison. Just to remind people, we'll have a recording from this morning up on our website, probably tomorrow morning. So that's the HSRAANZ website, and the slides as well. And just to encourage people, if you're not members of the association, just take the opportunity to look at our website and membership options and our other activities, and please think about supporting us.
Okay, well, there's no more questions coming through. But thank you very much for that really interesting presentation. I think that's a really lovely model, and it's really encouraging to see that policy is actually paying attention to these types of analyses, and that we're implementing interventions such as BRCA testing in a way that can really benefit the community. So thank you very much for the presentation, Haitham, and thank you to everyone for joining us on the line. And
thank you for the opportunity.
Yeah, thank you. And congratulations on winning the award as well. And so the recording will be up online. Anyone who's joined us today, please feel free to circulate it around to your friends and colleagues who might be interested as well. And as Sarah said, encourage them to visit the website of the Health Services Research Association and consider becoming a member.
Great.
So, thank you, everyone.
Thanks, everybody. Bye.
Bye.
Bye.